The tricky part is really when patients fail isotretinoin or they just won't do it for one reason or another, because there's not a lot of other things out there. I have a handful of patients in this category, and they've had success with photodynamic therapy, so I think that one can work pretty well as an alternative treatment.
Welcome to the Learn Skin Podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, I've been thinking, have you ever thought about all the podcasting that's been going on and like reaching out to our brethren and sisterin about these things?
Oh, absolutely. Podcast is a medium that just expands every day pretty much. And since we've entered it, we found a lot of folks who are in the same space, really trying to promote awareness about skin disease, therapeutics. And it's really cool when we have the opportunity to bring someone with a similar experience to our little neck of the woods. So I think maybe it's time to introduce our guest.
Yeah, we're pretty lucky because our guest is also a pediatric dermatologist, can speak at length on just the clinical practice of dermatology, but has a podcast as well. So we want to welcome Dr. Luke Johnson, and he is an assistant professor of pediatric and general dermatology with the University of Utah. But what I think is super interesting, all that's interesting already, but what's super interesting is he's also a co-host of the dermatology podcast called Dermasphere. And they delve into the science of dermatology quite deeply. So we're pretty excited, Luke, to have you on the podcast to talk podcasting, talk dermatology, whatever the heck we want to talk about.
Thanks, guys. Hi, everybody. It's great to be here.
Yes, excellent. And it's great to hear a familiar voice. Thank you for your contributions. Luke, how did you decide to start a podcast? I know a lot of the folks listening out there come to me sometimes and say, wow, that's cool. And how do you do this? And how difficult it is, and what do you need to have in place? But I think the first question is why? Why podcast and why you? Can you tell us about your journey to podcasting?
Definitely. So I think we started the podcast around the same time you guys started yours. Our first episode was released in June 2019, which was not quite a year since I joined the faculty at the University of Utah. And what inspired this idea was me being a dermatology resident, exercising and thinking to myself, I wish I could listen to something that would teach me about dermatology while I'm dropping this weight on my toe. I did, in fact, drop a weight on my toe and fracture it and had to go right across the hall to the emergency room.
Oh, my God.
And while I was being wheeled over to the emergency room, I was like, I wish I could listen to a podcast that taught me about dermatology. And there wasn't much out there at the time that I could find. There were one or two audio offerings, but I wasn't really impressed with them, and I wanted a podcast out there that not just taught me about dermatology, but took some of the load off of my back so that I wouldn't feel like I had to constantly look through new articles in order to stay up to date. And when I joined the University of Utah, there was a group of dermatologists here who was interested in technology and innovation and entrepreneurship, and I said, this looks like a really cool group. Can I join you guys? And they said, we'd love to have you. It helps if you have some kind of idea you might want to work on. And I said, well, I've always thought a podcast about dermatology literature should exist. Maybe I could make it. And they said, that sounds great. And that's how it started. I have a co-host. Her name is Michelle Tarbox. She was one of my faculty when I was a resident at beautiful, sunny Lubbock, Texas at Texas Tech University. And I thought she would be a great co-host. And I remained shocked that she said yes, given everything else she has going on. But we went ahead and started it. It's called Dermasphere, like you mentioned. And the goal is to bring discussions of some of the latest dermatology research to your ears so that our dermatologists and the dermatologically curious can listen to the podcast and spend less time flipping through articles to try to stay current.
The other little thing that I want to add, first of all, great job on your podcast. I've listened to a bunch of the episodes and I think it's pretty intriguing and it does simplify the research a lot. Michelle Tarbox was also an alumni of the Integrative Dermatology Certificate Program. So there's a little plug for the certificate program where you learn all you need to know about integrative derm as a dermatologist. And that's run through Learn Skin. Obviously, that's near and dear to my heart since I work with Peter and Apple on that, but I just want to also do a shout out to Michelle for that reason. So that's very cool that Luke, that the two of you have been working on that. So interesting stuff. But let me ask you, when it comes to podcasting, and we'll shift gears into talking about dermatology in a second, did you find that you became a better clinician after you started podcasting? It's always been a real interest of mine. Has it changed the way you practice after you started podcasting?
It has. And I also think about parenting the same way. Did I become a better pediatric dermatologist / doctor after I had kids? In some ways, yes, because it gave me a lot more empathy. In some ways, no, because I spend a lot of my brain power thinking about my kids instead of thinking about medicine or dermatology. Podcasting is kind of the same way, I guess. I could be spending this time doing something else to make me a better doctor, but I certainly think that it has made me one. Whether it's the most efficient way to do it, I can't tell you. But it's quite common that I'm in clinic and I think, on the podcast, we talked about this, or have a resident rotating with me and I say, oh, well, I remember we had an episode on the podcast where we discussed congenital hypertrophy of the lateral nail fold of the hallux. This was just the other day, for example. And then there are a few things that we discuss on the podcast that have just become like straight clinical practice that I do like all the time. Isotretinoin is a great example. We have a whole bunch of patients on isotretinoin. We end up talking about it a lot on the podcast because there's a lot of great research that's being done, and I change the way I monitor labs or my total cumulative dose that I'm going for, and how I counsel patients about side effects based on the articles that we discuss on the podcast.
I love that you talked about isotretinoin. This is a perfect segue because I thought this would be a great conversation for us to discuss, because now we've kind of moved from podcasting into the clinical space. Isotretinoin is something that I think a lot of us in dermatology use constantly. The Cochrane review that came out, and Luke, you may be aware of it, it concluded that isotretinoin, it wasn't clear that it was efficacious for acne, which I think just goes to show you that the methodology of the Cochrane review sometimes does have its fallacies, because clearly there's not a more effective medication in medicine, probably, especially when it comes to acne. But I'm curious to start with, when you start the discussion for isotretinoin, there is so much information online about the dangers of isotretinoin that a lot of patients are usually hanging on to, whether it's in a Reddit chat or something. How much questions do you get about safety when you start bringing up isotretinoin, and how does that conversation typically proceed?
It varies quite a lot, and I think it's changed since I was a resident, which again wasn't that long ago. I mean, it feels not that long ago. It was about 6 years, I guess. But I often will start by saying, this medicine called isotretinoin, it's also called Accutane. Do you already know anything about it? So I can at least get a handle on whether or not they've heard of it or are scared of it or think it's great. I've had all kinds of responses. And then I do have occasional patients who are pretty skittish about it, sometimes because they've had a friend or family member who's had a bad experience for one reason or another, and sometimes it's stuff they read online. And I usually try to say something like, well, I don't know that it's the best choice right now. We have some other options, but I don't think we should take it off the table. I tell them, dermatologists love this medicine, has so many advantages. It's one of the only things that we can do that makes you permanently better, which is great. I've taken 2 courses myself. I'm a big believer in this medicine. So let's not necessarily do it now, but let's not completely write it off.
And, look, I think in medicine, a lot of times we fall now into the trap of highlighting or talking more about the safety than completely forgetting the efficacy, which is the first part. You read any journal article you read first, we talk about the efficacy. Then at the end, we talk about some risks that may come with this. And I like to tell people when they ask me about safety, I say it's a pill that you take every day. And the number one side effect is that your acne is going to get really, really great. You're not going to see it, and you may never see it again. And I think that's something I try to put into my patient's brain before we even dive into this, because it seems like there's so many things on that consent form that may say, I feel like every bullet point there is kind of taking the patients away step by step from believing this will do anything for them. And, a lot of this also has to do with belief. If you believe something would work for you, then you'll take it as prescribed. You will maybe even do better, I think, to an extent. There is the placebo effect in everything that we do. So I really want to highlight to our listeners, any medication, if you're a prescriber, even if you're not, even if you're doing any other type of practice, really, you have to highlight the benefits first and then talk about safety. I agree with you. It's a very safe medication, very efficacious. Obviously, we all know this. But I want to take your point of view for a second as a pediatric dermatologist, because a lot of the patients I treat are kind of young adults, maybe late teenage years. How early are your patients coming to you for Accutane? And are there any subtleties in the way you prescribe it for kids, let's say, under 16?
Before we get off the safety thing, I think it's also helpful to remember that we should compare it to its alternatives as well. So it's easy to say
Great point.
this has a lot of side effects, but if our alternative is doxycycline, there's a lot of potential side effects with that as well. I honestly consider isotretinoin a safer medicine than doxycycline, and I tell that to my patients sometimes. I had a patient get SJS from doxycycline. I've never had that happen with isotretinoin. But your question was, are there things I do differently in little kids? The short answer is not really. I think the youngest I've put somebody on isotretinoin is age 12, possibly 11. When they have such significant acne that we think they would benefit from isotretinoin at a pretty early age, then I do think about endocrinopathies, and I sometimes will check those labs. I've never actually found a problem. But then I go ahead and start isotretinoin in its sort of traditional weight-based form. I did have a family that was concerned about bone and growth, and I looked into the literature saying, oh, well, maybe I should re-educate myself because I don't remember this being a problem from what I learned in residency, and maybe we should talk about something on the podcast. But I couldn't find anything convincing that said it was a problem. There are sort of occasional case reports, kind of like there are with pancreatitis and isotretinoin, for example. So I don't do anything differently, really.
Yeah, and I think a lot of that experience comes from using other retinoids, older generation, using it in very different indication, treating certain tumors in very high doses. And even with that, it's almost expected. And by the way, at very young ages, so we're talking single digits for those poor kiddos who have to get those type of medications. So I really think there's a big difference. I did the same deep dive because patients ask me, but we don't really learn about that in dermatology. And then I think there's so many different questions about bone growth that I get. I think it's probably the more common one. Does any of you know where it's coming from? I mean, you would think that people will ask me first about the dryness or, some labs that they have to do. But it seemed to be the most common question I get is actually at a younger ages is about the bone growth.
Hadar, I mean, my take on this has been that patients are very forgiving of temporary side effects. Like that's not what bothers them when they come in. Like even when I do biologics or if I'm talking about, the JAK inhibitors or whatever it is, it's always like, what's the long-term effect with this? Like, well, how is this going to affect my life in a way that might be unforetold for the rest of my life? That's, I feel like what's on their mind. Because I feel like they think like, dry skin, whatever, that's going to come up here and there. But, when they read about bone fusion, then they're like, oh, this might affect how tall I'm going to be, or that impacts confidence. Or a lot of them will ask about gut health. Will this affect my gut? And, some people have read even now about, the incidence of gut issues like inflammatory bowel disease. And they ask about that. They're like, is that a concern? Or they'll say, is there some long-term effect that I literally had a parent and a child that said, we won't do it because we think it'll affect their fertility long-term. I mean, people are just reading these things. And I wonder if it's there's a lot of questions around, what is this going to do for me permanently? I mean, it'll cure your acne permanently, but I'm curious, Luke, if you have thoughts on this, but that's been my take on this, is that they're really worried about long-term side effects.
I think that makes a lot of sense, and I would be worried about long-term side effects as well. Every so often, something super rare and idiosyncratic happens no matter what you're doing, so I guess we can't write that off, but I feel like it's not exactly appropriate to counsel patients that 10 patients in world history have reported some kind of bone issue. I feel the same way about the ocular side effects. I heard a horror story from a faculty of mine, co-faculty, who said that somebody he knew had some permanent night vision blindness from taking a course of isotretinoin. And I think, geez, I've been giving this out like candy. Should I be looking into permanent ocular side effects? So we had an article that we discussed on the podcast. It's a great thing about having this podcast. Every so I can look up articles and share that information with everybody else. And really, it was quite reassuring. Again, probably there's occasional rare things that happen that's straight up bad luck, 1 in a million or even less perhaps, but the ocular side effects all looked temporary from the deep dive we did on that one.
Maybe taking a look at isotretinoin from the perspective of alternative options. I mean, just because we can discuss the integrative approaches here. Obviously, the antibiotics long-term have the side effects that you mentioned, but they do affect the gut microbiome too. And in fact, like a long course of doxy will have impacts on the gut for up to 6 months. Will it affect them in ways that their gut can't recover? I mean, I don't think the evidence is there for that. But then people ask, well, what about other options? And really, we have anti-hormonal options for women with spironolactone, but and there's some supplements that people can use. But I usually tell them, like, isotretinoin is for pretty severe acne where these other things don't touch it. And I think coming from that perspective, people are kind of in a state where they're like, well, if you keep waiting, the scarring is permanent. I mean, Luke, how do you address what are the alternative options that are out there? Did people ask you beyond doxycycline? And now a lot of people are like, well, what about sarecycline? I mean, what are your thoughts on, alternatives that you might use or try prior to going to isotretinoin?
We have more options in female patients, so I don't like using doxycycline. I do like using topicals, of course. And then I think oral contraceptive pills and spironolactone are pretty good. They work for only as long as you take them, just like everything that's not a retinoid. So sometimes I have this conversation, especially in younger female patients. If they're 13 or 14 years old and I'm considering one of these medicines, I'll say, well, your body probably has like 6 to 7 more years in it where it wants to make acne. So we could put you on one of these medicines for that length of time. Or we could give you a 6 to 8 month course of isotretinoin, and then hopefully you'd be done forever. That said, I think those are safe medicines, and I think they work well. The tricky part is really when patients fail isotretinoin or they just won't do it for one reason or another, because there's not a lot of other things out there. I have a handful of patients in this category, and they've had success with photodynamic therapy. So I think that one can work pretty well as an alternative treatment.
Yeah, and I want to say the area where I find I use more antibiotics in acne is actually a different point, is when I use topicals. So topical retinoids, I think sometimes we forget how efficacious they can be. And so the classic case for me would be a patient that's kind of on the borderline. There may be one scar. I see very red papules. There's a lot of inflammatory burden. And the patient's a little hesitant about doing Accutane, right? So we have inflammatory acne, but not really scarring just yet. So for that hesitant patient, I find that I'll say, you know what, if you want to try topical, you can be surprised. If you're adherent, if you can tolerate it well, and you're doing it appropriately, actually, they a lot of times work really well if you give it time. And then I'll introduce the doxy bonus question to say, well, if you want, you could do a little boost of doxycycline short term to kind of get you over the edge, and then maybe the topicals would help carry you through. And I think that in a handful of patients that we've done this, we've seen really good success in them, and they're kind of happy, and they just want to continue using the creams, and there's no harm in doing that. Look, I wanted to switch gears here and talk to you about lab monitoring, because that's another common question that comes up. I think a lot of it had to do, at least in the pre-pandemic era, where we had to send our female patients always to get pregnancy blood work. And then we say, well, if we're going to get that, might as well get that CBC and tack on that comprehensive. And why not? Let's check some lipids and kind of throw the whole package. But now that we have a choice, I think we need to be a little more critical. So what have been your approach from reading the literature?
And can I ask a preliminary question too that kind of tags on to that?
Yeah, pile it on.
How is your approach to dosing isotretinoin? Like, okay, you've decided you're going to start. I think there's a lot of conversations about mid dose, low dose, normal dose. And I know we had a short little discussion about this right before we started the podcast. But if you can talk a little bit about how do you dose it, and then also talk about how do you monitor?
Yeah, so dosing, I feel like I'm fairly traditional for most of my patients. I usually start them at roughly 0.5 mg per kg per day for the first month. And if they're tolerating it well, then I go up to 1 mg per kg per day. And a lot of our discussions on the podcast pull literature that's published from groups around the world. I mean, God bless the internet. We live in a golden age. We can talk about articles from China and from Kathmandu and from India and get everybody's take on this. So my impression from reading a lot of those is that America has a little bit of a go big or go home approach to isotretinoin. And I don't know if that's the American culture or if that's a side effect of the iPledge system, but my feeling is that in other places in the world, they use lower doses by default. So they use 0.2 to 0.3 milligrams per kilogram per day, and it probably takes patients 1.5 years before they get to the clinical endpoint, but that's all right. They probably don't have to see their provider every month to talk about pregnancy tests and stuff like that. Either way, I think you get to the right endpoint. So I do have some patients who have some significant side effects, or at least they think they would get significantly worse if they went up, and so we just keep them on 0.5 mg per kg per day. My approach is usually to reduce the dose if people have any side effects that I find at all concerning, like headaches or potential mood issues. Then I usually reduce the dose, and sometimes we just coast on that. And then for the occasional patient who's on like their third course of isotretinoin and just doesn't seem to get clear unless they have a little bit of isotretinoin on board, I do have a handful of patients who are like on 10 milligrams every day or sometimes even less than that. That's my approach to how I start dosing it. And then to know when I'm done, I want them to be clear for 2 months. And I think that's the most important metric. It's nice if they also get to 160 mg per kg per day. We discussed an article again on the podcast a couple years ago. It wasn't a huge study, but it was a retrospective chart review of patients who did or did not require a second course of isotretinoin, and being clear for 2 months and having a higher cumulative dose of 160 mg per kg rather than 130 was associated with a greater chance of not requiring a second course of the medicine. So that's usually where I aim.
What do you think are the factors that contribute to requiring a second course? I mean, are there any patient level factors or any sort of characteristics between females and males? Or is there anything that you've noticed that adds to the risk for a second course?
It depends on which article you read. There's been a number of different studies that have commented on this, and I feel that the commonalities are the worse your acne and the earlier it's bad enough to feel like we need isotretinoin, the greater the chances are that you might again feel like you might benefit from it.
And, I see a lot of women that have this lingering hormonal, I mean, all acne is hormonal, so that's kind of an ironic comment, but this lingering acne that comes around the jawline and whatnot, even after they finish isotretinoin, do you ever put them on another therapy, like during isotretinoin? Do you see the same thing? Because I end up having to start people on spironolactone during isotretinoin in many cases, and then we just keep them on a pretty low dose afterwards, or there are some supplements that you can even do that can also target the hormones that seem to work well. I'm curious is that something specific to maybe my region or maybe my practice? I'm curious what your experience is on that.
I have had to do that one time in a woman in her 50s. So there might be something unique about you, Raja.
Well, maybe I need to push the isotretinoin longer. Maybe that's what needs to happen.
Yeah, and I think, look, as you mentioned, definitely higher doses have been associated with upfront, with less frequent second dosing regimen. And to your point, Raja, I think every now and then I do see that in my young adult females. And I think now we have clascoterone, which is a great addition to our toolbox. Again, in acne, a lot of times we forget the power of topicals. And so that has been approved and actually been approved down to age 12, I believe, speaking of pediatrics. And in the studies, I think it went down all the way to age 9. They just didn't have enough kids there. So it's very safe, really, really safe medication that we can offer them. And I know a lot of my patients are hesitant about taking one pill, let alone a second one during the Accutane course. So I think we try to be careful with that. So now having a topical such as clascoterone is really useful. And now I want to get back to the lab monitoring before we run out of time here, because I know that a lot of clinicians are really debating, okay, this is like a new thing that now we have a choice. iPledge is not making us do this anymore. So perhaps you have some insight into this.
Yes, I feel oddly passionate about this specific issue. Isotretinoin laboratory monitoring. Who knew that would be somebody's soapbox? But basically, I feel like we do it too much. And I feel that the literature supports my views, though I could just be reading articles that support my already existing views, the same way some people consume the news. But hey, here we are. So we've talked about some of these on the podcast as well. I feel that the current literature says that in otherwise healthy adolescents or young adults, and I'm arbitrarily choosing under age 30 as a young adult, we don't need laboratory monitoring at all. So the way I approach this with my patients is I tell them that, and I say, honestly, most dermatologists would still get some labs. It probably is still considered standard of care. So if you want to get some for that reason, we certainly can. If you don't feel like it because I don't think you need it, then that's fine too. They usually don't get labs when I tell them that. And diving a little bit into the literature about this, what's the purpose of us checking labs? So are we checking them because the numbers might go up? That does happen sometimes. Or are we checking them because we think the numbers will go up and then something serious could happen, and by doing lab work, we can prevent that thing from happening? that's much less clear as a target that we can actually accomplish. So, for example, are we checking triglycerides because we think somebody's going to have such severe hypertriglyceridemia that they might get pancreatitis? Are we checking their liver labs because we think they're going to get fulminant hepatic failure and we're going to catch it with our laboratory monitoring? It's very unclear in the literature that this is actually going to help. There have been very few cases of isotretinoin-induced pancreatitis or DILI, D-I-L-I, drug-induced liver injury, related to isotretinoin. And most of those reports have been in patients who don't have laboratory elevations. And if it does happen, it more often happens fulminantly, and you're not going to catch it with labs anyway. So that's my approach to not doing labs. If the patients do want to do some, I check only ALT and triglycerides because I feel like that's, again, what the literature supports. The ALT is sort of more specific for liver injury, if such a thing exists, with isotretinoin. And then triglycerides, I suppose, for this pancreatitis issue. For patients who are older or do have comorbidities, including obesity, then I do check labs, usually just ALT and triglycerides to make sure. But going back to our very earlier discussion today about isotretinoin, checking labs make the medicine seem even more threatening than it already does based on TikTok and Facebook and X and everybody's experience with it. Plus, obviously, it hurts to get labs. It drives up medical costs. You end up finding abnormalities, and all you do is recheck them, and then they get better. So it drives up medical costs more. I just don't think it's necessary at all.
Yeah, I agree. I have this similar approach, and I agree with pretty much everything you said. I think that the one thing I think I've diagnosed more than anything with these labs is Gilbert syndrome, and that's about it. I don't think I picked up anything else.
Right?
That was useful. I agree with you, and I think it's a good point, especially coming from a pediatric dermatologist, that it's the adult patients that may need more monitoring specifically. And this is where rarely I'll need to talk to them about controlling the triglycerides, but that's, it's a handful. So I really agree with your point. I think we should be kind of thinking more holistically about our patients, including lab monitoring.
Can I offer a different viewpoint on this, guys? Because I think that'll be good to
Yes.
kind of get the different viewpoints. Okay, so first of all, we have a local insurance that will not pay for the visit for a long time. It was a capitated system. And the only way they would pay for any sort of visit with isotretinoin was if we drew labs. And so sometimes there are other factors that are not cool. And so we fought that, and eventually that got rid of it. But there may be other reasons why a lab is checked that go beyond, because otherwise, in a capitated system, you see the patient back over and over again over 9 visits. It's essentially free. You get zero reimbursement for it. And that promotes you never to do isotretinoin, which I don't think is good medicine. Secondly, I do think there's value in the lipids because I have had so many conversations around diet with my teenagers, and they will all change their diet. Almost all of them unilaterally are willing to at least have a conversation. I shouldn't say 100%, but it's pretty high. It's 75 to 90%, in terms of cutting down dairy. But the other big one is if their cholesterol level is a little bit high, I actually use that opportunity to talk about fast food. And not in all cases, but not infrequently, I get a lot of patients that'll come back and their parents are like, hey, they started eating better. They don't eat fast food as much anymore. And I think that's a big win to utilize that as a marker if their cholesterol is higher. And then if the triglyceride's higher, one of the markers for that is actually activity and lack of activity. That's been the new thing that's emerged with triglycerides. So I use that as an opportunity to talk to them about how active they are. Now, whether they follow through on these things, I feel like these things linger in our children's minds, and many times the parents can't ever get across to them. And I feel we as doctors have an opportunity to. So I still do check lipids baseline, and I'll check again once just to see if it's an opportunity for me to talk to them about their diet. But we don't check labs either. I mean, that part of it I agree with. I don't think it's necessary. But I just wanted to offer that opinion because I think it facilitates the holistic conversation.
I like that. I like making people healthier, and I like preventing fast food businesses from selling burgers to people.
Yeah, no, I think that's a really good point, Raja. Thinking of the opportunity in everything that we do. And one of the advantages that we have as dermatologists is that the number one way we can monitor success is visually. And so our patients can see it. And for better or worse, that helps us many times. Where our colleagues, in primary care, it is incredibly difficult for a pediatrician I would imagine, to convince a teenager not to eat all this bad food that's around them because they don't see the problem. I mean, how can a teenager even think about that? They can barely, really surmise the consequences of anything in the future. And so I think that you bring up an excellent point where if the right patient is into this and they look at the labs and it gets them engaged in their overall health, I think that's an excellent point. And speaking of making excellent points, Luke, thank you for all the points that you made in this episode. Really wonderful to have a colleague. And I want to end where we started with the answer that you provided to your question about podcasting is something that you were really passionate about, really wanted to do, found the right team, found the right environment, the right collaborator, of course. And altogether, it actually made you better as a clinician and probably better as a person, because I think doing podcasts, you learn to listen. And so I want to thank you for doing this, for contributing to our community and kind of picking up and following your passion, which I think is a common theme we found in this podcast, is that people who follow their passion are happier people. So with that, thank you, Luke, and thank you for your contributions. And I hope to see you again in an episode nearby.
And Luke, can I ask you one last time, just give us a reminder on your podcast. How do people find you?
The podcast is called Dermasphere, DERMA Sphere. You can find us wherever you get your podcasts, and you can find us on our website, dermaspherepodcast.com. And thanks so much for having me, guys. This was a lot of fun.
Agreed.
Thank you. Folks, we'd like to invite you to check out our colleagues in the Dermatology Podcast family, Dermasphere.
Luke and Michelle are two board-certified dermatologists who also discuss the latest research in the world of clinical dermatology. Learn about recent drug trials, disease pathogenesis, off-label drug treatments, and more.
Come for the dermatology, stay for the dad jokes. Dermasphere has been around since 2019. And I just love seeing how they grow as part of our podcast community. Search Dermasphere wherever you find your podcasts.